All right, so today we've got a cool topic from roots to regeneration, where naturopathic medicine and principles meet cutting edge treatments. And specifically, we'll be talking about how this is going to be a program that's going to be launched at NUNM. I graduated from NUNM in 2016, and so even though this may be kind of a newer specific subspecialty shift, the basic and kind of broad education of NUNM had allowed me to step into this right out of graduation and into residency. So just kind of keep that in mind. But I'm excited that I'll be on campus at the clinic, offering these therapies for our patients and teaching our students along the way. So I think it might be interesting for you to know just a little bit more about my background and how I came to where I am at, and then we'll dive into the cool stuff with the regenerative medicine. But basically, I grew up in a real small town in Oregon, and one of our values in the small town, we didn't really have very much access to healthcare, and it really was, your personal responsibility to take care of your own health and then to take care of your neighbor. And the more that you took care of your own health, the better you could take care of your community. And we all really valued our participation in our community. And we realized like the better that we took care of the root cause of things, the more functional we were in our lives and as a community. So I really had this value of healthcare, um, taking responsibility for healthcare, and then learning what I could do for my own body to stay healthy so that I could contribute. And that's kind of where, my underlying philosophy that I grew up with. As I was going through school, I realized that, well, I'm pretty smart. I really love science. My dad was a science teacher. The pre-med path was pretty well laid out for me, and that was the original idea. And after graduating from high school, I went to Western Oregon University. I was from a really small town, and I wanted to go to a small school too. I was too scared of the big schools at that point. But I had a great experience at Western Oregon. But as I was going through my undergraduate experience, I worked as a CNA, so a certified nursing assistant, to pay for my way as I went. I didn't want to take any loans. My family doesn't have a whole bunch of money. So I paid my way by working on the weekends, like a 36-hour shift on the weekends to pay for my 4-year education. But what I experienced as a CNA, and if you look at like a medical hierarchy, like you have like a specialist up here, like CNA is like at the very, very bottom of the hierarchy. But your hands are on the ground, your hands are on the patients, and your feet are on the ground too. So you see everything about the healthcare system. And I wasn't too particularly impressed with what I saw in the conventional medical paradigm. I was particularly disheartened by how our elderly and disabled were kind of dismissed and overlooked and potentially not treated to the highest respect that they deserved, let alone healthcare just not really trying to offer them many services to try to get better. They just wanted to keep things managed and the way that they were. So I kind of I got a little disillusioned with the conventional medicine system. I was well on my way for this pre-med track and, had really good letters of recommendations from my faculty and had a lot of good experience doing um, microbiology research. I did 3 years of my own independent funded research study on these bacteria that grow in Yellowstone. Is really cool. So I had a lot of good, really strong competitive resume to potentially go into medical school, but it just wasn't fitting my heart and my calling. But with not knowing what to do after I graduated, I was kind of like, well, then what do I do next? Well, my next step was I thought if I understood more of like what we claim to know when we claim to know something as humans and trying to understand the underlying level of knowledge behind our ideas, maybe I could help people and I can like change some paradigms in this world and really contribute to our community and help the world be a healthier, happier, and more peaceful place. And that sounded really great to me. So I decided to get a master's degree in philosophy. And I did this in New Mexico at St. John's College. It was a really, really good experience. the program is based on the great books. And so we went back and we would read all the great books and then discuss them. And then we would take it subject by subject. So we had like a science and math, and we had a philosophy of philosophy, and we had even art and history. Anyway, through that process, I thought, wow, this is really cool, but what am I going to do for a career? Like these ideas are great, but I really don't see it really changing anybody's lives. And I don't really need to get into arguments about how people should live their lives and what their worldview should be. So what am I going to do that fits my values, fits my skills, yet allows me to practice in a way that's aligned with my values and but practically help people? And that's where I found naturopathic medicine. And it just happened to be when I was at St. John's, we had a guest speaker who actually was an acupuncturist who had been to NUNM. And he gave a presentation on acupuncture and the circadian rhythms that acupuncture can follow. And I thought, wow, this is really cool. And I was just kind of interested for my own health. But I asked him afterwards about more of his training, and he introduced me to NUNM. And I thought, I looked into it and I thought, wow, that's pretty cool. Another kind of amazing coincidence at the time was that I happened, when I was in my master's program, I happened to work for the Office of Career Development. And in that office, we get all these like college advisors publications. And one of the publications had a specific expose on naturopathic medicine as a potential career field. And I read through it, I looked through it, I understood like there's some challenges, but there's a lot of opportunity. And the profession is pretty small, yet small but bindy. And I thought, that's it. I'm gonna go for it. I don't care what it's gonna look like 4 years after I graduate. I'm called to do this. This aligns with me, and that's what I'm gonna do. And plus, it's an opportunity to move back home to the Northwest and be closer to family. So that's how I got to NUNM. I went to NUNM, had a great time, tried to learn as much as I could. And when graduation was coming along, I knew that I wanted to do a residency because I just knew I needed more clinical training. And I applied to basically every residency up and down the West Coast. When I applied to the residencies, I got had been gunning for a residency that was specifically like for cardiometabolic health and kind of longevity. I thought I was going to be more of taking care of people's hearts and their diabetes and their chronic diseases. But the last place I interviewed for in my residency was a place that did regenerative medicine, and they did it at a very high level. And when I saw that and I shadowed for half a day and saw what they were doing, it just clicked that that's amazing because I could use my critical skills, I could use my people skills, I could use my values, and I could use naturopathic medicine to really impact people's lives on a daily basis to help them move better, feel better, participate in their lives better. So then I did a 3-year residency in that particular field of doing injection-based therapies using regenerative medicine. Since then, oh no, how did I do that? Sorry, guys, push the wrong button. Since then, I honed my skills and got certified as a registered musculoskeletal sonographer. Diagnostic ultrasound is really helpful, not only to point of care, get your diagnosis so you can help your patient, but then also understanding how ultrasound works so you can use it for image guidance is really helpful. And since then, I've become a subject matter expert in this, and I write for the national exam. And I also co-founded and am now president of the Naturopathic Orthopedic Medicine Academy, which is a AANP, which is the Association of Naturopathic Physicians national organization. It's our subspecialty organization in relation to injection therapies and regenerative medicine. So here are some more about my affiliations. I won't dive into that too much, but there they are. And I just want to say thank you to my family for allowing me to take the time to develop all these slides. And, every time that I'm outside of my clinic and doing projects outside of my day-to-day, it takes away from times that I can spend with them. But this is the wonderful Dr. Valeria Manning. I met her at NUNM, and our 2 daughters. So what we were going to talk about today is the philosophy. So, I mean, this is where I think is the crucial part is why do we go to ND school? Well, for most of us, I think it's because of the unique philosophy that allows us to practice a patient-centered way to actually get to the root cause of somebody's suffering and to really help them out. So I'll dive into the philosophy, and as you saw, I went to St. John's. I love philosophy, so we'll spend probably more time than you want on that. But that's the key. I keep that in mind every day, and I love that because that's the badge that I wear as an ND. I collaborate in my first 8 years in practice. I worked at a clinic where I was only ND, but there were several other specialty medical doctors. But we worked elbow to elbow, hand to hand, shared patients with each other, and collaborated quite a lot. But they all wanted to know, hey, what does the ND think about this? How would an ND view this, even though we were treating the same things? Because they have a lot of respect for our underlying philosophy. Then I'll talk a little bit more specifically about what regenerative medicine is. I'll show some examples of how to do regenerative medicine and how to do it at a high level. I'll briefly talk about the level of evidence out there. Some people are pretty skeptical about regenerative medicine, but um, there's a lot of literature to support it. So maybe they should kind of look into that. And then we'll go through a couple cool cases. So before we jump into the philosophy, this is like an example, and this is an actual patient that I had just over maybe a year and a half ago. So I had a 29-year-old male with low back pain and left leg pain and left leg weakness. Actually, the weakness with him was in both legs. So this poor guy, young, has a lot of life ahead of him, but his legs were going weak and his leg was really, really painful. And he was referred to me by his primary care physician, sorry, physician assistant, no specific injury, pain with bending forward, pain with lifting. He had tried some of the conventional things like physical therapy, ice heat, some medications, yet nothing was working, and he was seeking non-surgical options. So, what would you do? How would we handle this? And can naturopathic physicians handle this? It's a big question because, like, if that damage in the legs and the weakness in the legs, that neuromuscular compromise, if that becomes more chronic and chronic, the longer it's there, the harder it is to reverse it. And there's a time and a place where you need to send a patient to surgery. Is this it? Well, we'll take a look at that later down the line. So one of the cool quotes that I came about when I was studying philosophy at St. John's was this one. But metabolism is more than a method of power generation, or food is more than fuel. In addition to, and more basic than, providing kinetic energy for the running of the machine, its role is to build up originally and replace continually the very parts of the machine. Metabolism, thus, is the constant becoming of the machine itself. And this becoming itself is a performance of the machine. But for such performance, there is no analog in the world of machines. The point here is that our life in and of itself, not just human life, but life in general, is a machine becoming itself. And we take in energy and we transform it and we rebuild and renew our bodies or whatever life form that is. But if you take a machine, um, if something goes wrong, it can't self-repair, at least not yet. and and oftentimes in conventional medicine, our bodies are broken down to discrete parts. Like, okay, it's a problem with the heart. Well, what's the heart? Okay, the heart's a pump. So like let's just fix the pump. And in conventional medicine, our bodies are siloed, but then they're also treated as a machine. But our bodies are not a machine. They're alive, they're adaptable, they're continually replacing and evolving and adapting to their environment and their inputs. So for instance, our skeletal system, is not the frame of a car. Let's look at a car, for example, and what holds the car up? Well, it's the frame of the car. If you break the frame of the car, then you're going to have to get somebody else to come in and fix it. Well, if you break a bone, at least to a certain degree, those bones can heal together, and the bone and the skeletal system is constantly overturning and renewing. if you think of a car, like how does a message or a signal get from one part of the car to the other? Well, the electrical system. And that's similar to like the nervous system in our bodies. But our nerves are alive. Those wires are not. They can't self-replicate, they can't self-repair. Our nerves can. And there used to be old dogma that we thought that once you damaged a nerve, that damage was permanent, but there's more and more evidence to show that that damage is reversible and that that old dogma is not true. Um, so as far as our energy system, it'd be similar to like the combustion engine and the gasoline in the car. But again, um, our bodies, our stomachs, our livers, our intestines can do everything it needs to do to take in fuel, transform it, and then digest it, and then absorb it, and then discard it. And again, our heart is not a pump or a motor. So basically, in the conventional paradigm, when you have a musculoskeletal injury, like um, if we think of our bodies as being machines, then of course we would want to intervene exogenously and try to intervene to heal it because we think that it can't heal for itself because it's a machine. But that's just simply not true. Our bodies are not machines. There are degrees of injury where we can't self-heal. That's when we definitely need our very skilled and highly trained surgeons to put some things back together. But a lot of injuries and a lot of tissue damage does have the potential to repair if you give the conditions necessary to do that, or potentially use the body's own tissues from one part to augment and help the injured part to heal. And this fits very nicely with our 6 principles of naturopathic medicine. So first of all, do no harm. Well, when we're trying to heal, provide the conditions for the body to do its natural healing and working with our innate healing systems, obviously we're doing no harm. And we're even doing things like preventing surgery. We're also relying on that healing power of the nature. We're relying on the innate mechanisms and physiologic processes that allow our bodies to heal. So we're working with Mother Nature. We're not doing any harm. Before we jump into doing any of these therapies, we have to identify and treat the root cause. And then we have to educate our patients as we go about how this paradigm is different and what they need to do in order for this to work. So I just think that regenerative medicine and naturopathic principles are one and the same to a certain degree. And it just happens to be that as naturopaths, we're particularly well positioned to do this type of medicine. So here's an example. Everybody gets taught this regardless of their medical training, that we have a healing cascade. And everybody knows this, but oftentimes we forget about this. And this is how the body normally responds to an injury. We get a clot, and then we get an inflammatory phase, and then the next phase is that proliferative phase where collagen is getting deposited. And then we have a remodeling phase where that collagen becomes then stronger. So this happens if you get a cut. This happens if you get a ligament sprain or strain, tendon strain. And this is happening at the tissue level. And this is orchestrated by our own innate physiology. But oftentimes we just forget that it's there, or our conventional friends think that this natural mechanism is not sufficient enough to help people function better and alleviate their pain. But I'm here to tell you it is very powerful and it can. This is an example of a microscopy of an actual wound healing. And it's really pretty cool. I wanted to show you this. It blew my mind when I first saw it. So that red line there being outlined, that's a vessel, a very small vessel, probably capillary. What we have circled here, that's a stem cell migrating from the blood to the area of the injury. We have all these stem cells traveling to the area of the injury and then healing that area of injury. So, like, our bodies can heal, and it's not just skin that can heal. So, why don't we work with our bodies more instead of trying to suppress this healing response with like non-steroidal anti-inflammatories and other medications, or with corticosteroid injections, or going in and having to surgerize it. We can work with this and it can work to our advantage. So these are conventional options, doing like cortisone injections, which suppress that healing, which suppress that recruitment of the stem cells to the injured area. And if you suppress that acute phase of healing, what's going to happen? Incomplete healing. Then what's going to happen? Chronic problems down the line. So we don't necessarily want to do that. But hey, people get pain relief quick, but then they have bigger problems down the line. As naturopaths, maybe we can offer something different that can actually help the tissues to heal once and right in the first place so that they don't have those bigger problems down the line. Or, hey, maybe we can prevent the need for surgery. This is a slide. This is from Dr. Centeno. He's one of the pioneers and thought leaders in this field. And basically, he kind of coined this term interventional orthopedics. It's the idea that you have like simple big joint injections with like cortisone, or you have surgery. And in between, you kind of have like anti-inflammatory medications, physical therapy, acupuncture, massage. But if people continue to have pain in their area, if the simple big injection didn't work, or and then but maybe they are not indicated for surgery, or surgery is the only and the last option to get them feeling better. But that doesn't mean surgery is a good option. And so the idea here is that interventional orthopedics is that there are physicians that are specifically trained to inject specific ligaments, tendons, joints, joint structures in order to help accomplish healing at that tissue level so that people don't need surgery. So what is regenerative medicine? I've kind of been throwing that term around without particularly well defining it, but basically it's an umbrella term used to categorize a burgeoning field using treatments aimed to replace, revitalize, or regenerate cells, tissues, organs in hopes to restore normal function. And this is working with the body's innate healing mechanisms to restore health. We can treat degenerative and acute injuries with substances designed to heal rather than mask symptoms. And regenerative medicine is being studied and shows promise for multiple conditions and organ systems. Yet today's focus and my clinical focus is limited to the musculoskeletal system. Now that's pretty broad because it's pretty much head to toe, including nerves. But I'm not talking about like organ regeneration, and I'm not going to be doing any of that as a naturopath. And the use of regenerative medicine for musculoskeletal therapy is referred to as orthobiologics. So biologic in the sense that it's the medicine we're using has a biologic action, and ortho in the sense that we're using it for the musculoskeletal system. So regenerative medicine and orthobiologic are one and the same. So what is it? Well, this is an example of one of my favorite regenerative medicines. This is what platelet-rich plasma, or PRP, looks like. And this is a very highly concentrated, very clean, good PRP product. And why am I showing this? Well, look, that is from somebody's blood. We do a blood draw, and then we process it in a certain way, and we result in this product. And in that product, we have a bunch of these platelets, and it's from their own body. And then we're going to put it into their own body, just into a different area that isn't healing well. And why platelets? Well, because platelets have a bunch of growth factors. And when those growth factors get released, they stimulate that healing cascade. So this is more specifically what some of those growth factors are. Platelets have over 1,500 proteins that are bioactive, but the main players are like platelet-derived growth factor, PDGF, VEGF, fibroblastic growth factor, insulin growth factor. These growth factors in injured tissue are there at a very low level, and oftentimes the injured tissues don't heal properly on their own because they don't have good blood flow by design. Tendons, they're meant to move, they're connected muscle to bone, they're meant to move the skeleton. If the tendons had blood vessels and really good vascularity, they would have perforations in between their fibers. And what would happen if perforated tissues were then contracted? They would be more apt to tear. So certain tissues in the body have less blood flow than other tissues in the body, and by design. And our tendons and ligaments have very low blood flow because we don't want them to tear. And since they have that, um, they don't have platelets. They don't have access to these growth factors very well on their own. So basically what we're doing with some of these regenerative medicines is taking a big amount of those platelets from a different part of the body, blood is a tissue, and then concentrating them all together and injecting them into that injured area and then letting nature take its course to try to heal it. There are other types of regenerative medicines, and this one gets a lot of hype, but I'll say PRP is amazing. But stem cell therapies are also a type of regenerative medicine. They work differently than the platelets because we're not just getting growth factors, we're getting a live living cell that can differentiate into different tissues. So they can engraft, but it can also produce growth factors. This is the Nature article, kind of the seminal study by Arnie Kaplan describing these types of cells and their role in healing. And here's how these cells work. They can differentiate. So you take a stem cell from one part of the body, put it into an injured tissue, and those stem cells can then differentiate into whatever that type of injured tissue was, but now it's a healthy type of cell in that tissue. They can signal, kind of like the platelets do, to help the tissues to heal. They can directly transfer their exosomes or their mitochondria or other things to the native tissue where you transplant them so that that native tissue can then be healthy again. So they're really powerful. And just to kind of give you a little bit more background on them, in the US at this time to do stem cell therapy, we have to get it from the patient from one of two places. But then once we acquire it, we then have to use it the same day. So these are like a tissue graft done in a same day surgical procedure. But here's a couple examples where the PRP, which is in this syringe, yeah, that comes from a simple venipuncture blood draw. This here is called bone marrow aspirate concentrate. This is a source of stem cells, the mesenchymal stem cells that are found in a person's bone marrow. In order to get that, we put a particularly big and robust needle into the pelvis and pull out those stem cells. This is another source of stem cells, and this is microfragmented adipose tissue. In our adipose tissue, there are very high levels of really bioactive stem cells. And so what we do is we do a mini liposuction procedure to take out some of that fat, and then we resize it and then use it therapeutically. So how do we do this? Well, I like to think of this as and call this the three-legged stool of regenerative medicine. And anything in medicine, there's always a risk that it doesn't work. Nothing in medicine has worked 100% of the time for every patient. But what we want to do is give it as good of a chance as possible. And I like to use this philosophy for my treatments so that I have a standard protocol that I use each and every time so that I can hope to get reproducible outcomes and excellent outcomes. So if we take a three-legged stool and you picture a patient sitting on that stool and the patient is expecting to get great relief and an excellent outcome. If one of these legs of the stool breaks and the patient is sitting on it, what happens? It falls over and you fail. You didn't get your outcome. So all three legs of this stool are very important. It starts with the first leg being a precise yet complete diagnosis. If you don't know what you're treating, how can you expect what the outcome is going to be? You need to know the specific diagnosis, and you need to know too whether or not that diagnosis can be realistically treated with regenerative medicine. Sometimes the damage is too far gone and we know it, and they need to have surgery. That's fine. But for maybe 80% of tendon, ligament, joint complaints, they're nowhere near needing surgery, but that's what they end up doing because they didn't know there were other options. But it all starts with diagnosis. In my clinical workflows, I spend probably 85 to 90% of my time up front on the diagnosis. And I do things like diagnostic injections to test my theories and make sure I really understand what's going on. So that when it comes to the time of putting the regenerative medicine in the right place, that's just the easy part. And I spend a lot less time on that. But if you miss the first step of the diagnosis, you're going to have subpar outcomes, and people aren't going to come back. So diagnosis is the key. The second thing is, okay, you got your diagnosis, you really have a good idea what you're going to do and what you intend to accomplish. Now you have to choose which of these biologics you want to use. But it's not even that easy because not everybody's PRP is created the same. Not everybody's bone marrow aspirate's created the same. And so you have to do your due diligence to actually use a true, good, safe, FDA compliant PRP product or stem cell product. Once you choose that right one, then you have to get it to the right tissue. If you don't get it in the right spot, it's not going to work. I could have LeBron James stem cells. Let's just assume they're really good because he's pretty darn athletic and so are his kids. Let's say I had his stem cells and I injected it into a little tendon injury. If you don't get it into the spot of the tendon that's actually injured, they're not going to help it to heal, and you're just wasting your patient's time and money. So this is what it will look like to place a needle directly into where a person had a tendon damage. This is actually hamstring tendon in an elite marathon runner. This is the actual MRI. And on the MRI, you can see this bright line through here. That's the area of the defect. See this part of the hamstring tendon nice and dark is normal. So what you can see is as I'm putting the needle into that tendon with the ultrasound, I'm looking to find that same white line, and I have. So I'm putting my needle directly into where the disease portion of the tendon is. And that's going to confer, at least give us the best chance possible for an optimal outcome. What kind of tools do we have to help with diagnosis? Well, we have our clinical history, we have our physical exam, we have labs. All the time when we're doing all of these and imaging, all the times that we're doing these studies, we need to correlate that with the clinical presentation. Just because you see something on ultrasound or MRI doesn't mean it's their pain generator or doesn't mean it's the whole story of why they're having pain. Sometimes you have to look upstream and downstream to get that diagnosis. And then I do diagnostic interventions as well. Just a quick note on low back pain. A lot of people kind of are trying to minimize the local tissue damage that happens in the back that can cause low back pain because in conventional medicine, there's not really great options for it yet. The regenerative medicine is going to change that, but basically, a lot of times on MRI of people over about 40, you'll see degenerative changes of their discs, and the question is, do they have pain or do they not have pain? Well, there's within specialties that do treat disc type pain, it's well elucidated in the literature that when the annulus or the nucleus tears through the annulus, this nuclear material is immunoprivileged. So the body's nervous system and immune system has never encountered this because there's no direct innervation nor no direct blood supply. So when it tears through, like here, and then interacts with these nerves for the first time, the disc causes pain. What happens? People have really bad low back pain, and then but we see these on the MRI, and the doctor's like, oh, it's just non-specific. You got low back pain, but the problem is the disc. The problem is they don't know how to treat it, and we can't. Here's an example what that looks like on MRI. Here's normal disc, normal disc, normal disc. Here's a bit of a bulge. And this white line right through here is an annular tear. And that's a painful little bugger. I've had it done on myself. In fact, this is my back. Some other things to think about as far as diagnostics. Ultrasound and MRI are kind of the gold standard, but ultrasound and MRI are better for different things. Like for the spine, you need an MRI. But for peripheral joints like knees and shoulders and elbows and wrists, sometimes ultrasound specific. In medicine, when we talk about how good a specific imaging modality or test is, we talk about things like sensitivity and specificity. So things that are like, how accurately do they catch the true positives, and how often do they not include the false negatives? And when you look at like ultrasound and MRI for rotator cuff issues, MRI and ultrasound are pretty close in their sensitivity and specificity. But when we look at our physical exam testing, empty can, lift off, Codman speeds, and muscle strength, they're all over the place. Some of them are sensitive but not specific. Some of them are specific but not sensitive. My point here, don't just rely on physical exams. You're gonna need to be, if you're gonna get into this field, you're gonna need to know how to look at MRIs, how to order MRIs, how to do diagnostic ultrasound, and how to interpret that for yourself, because this is how you're really gonna get to the root cause of somebody's problem. So now we'll talk a little bit more about how not all orthobiologics are created equal, and how not all orthobiologics are indicated for certain pathologies. But the key here is we want to stay ethical and legal, and we want to be safe. I'll skip that part. That's for a different topic. But here's a slide, is that if you look up PRP in the literature on PubMed, you'll get all sorts of conflicting studies. You'll have some studies that say, yeah, I mean, PRP is a disease modifying drug and intervention for knee osteoarthritis, and patients can expect to have at least 2 years of good relief. They have decreased pain and increased functional scores. But then you have other studies that show that, well, for this one, like in knee osteoarthritis, PRP didn't do any better than placebo. Or here for ankle osteoarthritis, PRP didn't do any better than placebo. Or for Achilles tendinopathy, PRP didn't do any better than placebo. Well, then why do I still treat my knee osteoarthritis, my ankle osteoarthritis, and my Achilles tendon patients with PRP? Well, it's not because I'm trying to be a snake oil salesman or something. It's because I see good and reproducible results clinically. It doesn't match, my clinical experience doesn't match what these studies show. Well, here's the deal. When you look in at these studies, what they are calling PRP is not real PRP. So they're basically taking a little bit of blood, taking off spinning it once, taking off part of that plasma, and then injecting it. And be a true PRP, you have to draw a lot of blood. The more platelets that you get, the more platelets that you start with. By getting a higher blood draw, the more platelets you can have at the end. The more platelets that you inject into the particular area, the better the response. So the key with PRP is definition is supraphysiologic. Well, these studies are barely, I mean, some of them are below physiologic levels. One of them is supraphysiologic, but just like not even 10%. So it's not real PRP. So you got to be critical about the evidence. But then here, you look at this study, intra-articular injections of PRP decreased pain and improved functional outcomes more than sham in patients with knee OA. Well, and not only did it help these patients, but they achieved 2 years of symptom relief, and it slowed the progression of the arthritis. Like in conventional medicine, they often think of that once arthritis starts, it only continues to get worse with more time and more activity. But what this study showed is that it actually slowed that progression. So it's modifying the natural course of osteoarthritis in these knees and giving patients relief for 24 months. Well, why did this study show that it worked and the other studies showed that it didn't? Because in this study, they use a very high, good quality PRP product. And then how do we get it to the right spot? Well, our tools for this are going to be ultrasound and fluoroscopy. So this is often referred to as a C-arm, and it's a live X-ray where we can guide a needle to a specific ligament or joint and confirm that we're in that specific target, and then inject our therapeutic agent there. My point being here is that sometimes people will just palpate tissues and use their anatomic landmarks and just shove a needle in there and hope for the best with whatever their therapeutic agent is. But it's been proven that that's potentially unsafe. There's collateral damage, it's inaccurate, and the patients have an unsatisfactory experience and outcome. So we one of the first questions that I ask if I have a patient that comes in, but they like, oh yeah, I already tried PRP. I'm in here for the stem cells. I'm like, okay, well, okay, was it a good PRP? And then did they use image guidance? Oh, they only took one tube of blood. Nope, not a good PRP. And no, they didn't use image guidance. They just kind of poked around and they say they never miss. Well, I don't make any rhyme or reason about that PRP experience that that patient had because it wasn't a good PRP and they didn't get in the right spot. We've actually studied this. If you look at injecting into the knee by the palpation method, you miss 30% of the time at least. The shoulder joint, a really big joint, oh, you would think you'd be able to get the medicine in the right spot. Nope, you miss over 70% of the time. The AC joint, very small joint on the top of the shoulder, it's just right there. You can palpate it and you don't have to go very deep. Yeah, you're still missing 60% of the time. But if you put an ultrasound on there and you watch the needle go directly into the target, you're accurate 70, you're hitting the right spot 97% of the time. The shoulder joint, 96% of the time. You can be 100% accurate in the AC joint. Point being, you got to get the medicine in the right spot, and there's proper ways to do it. Here's a couple examples of what that looks like. I'm sorry, I got to speed along. I got so many good things to talk about, but I realize we're running up on time and we got some questions. But this is an example of what it looks like. Here's a common extensor tendon in the elbow, and there's these partial tears in it. This is me putting the needle directly in those partial tears and filling them in with the adipose tissue. This video here, we'll just play real quick. Here's a needle and the tip's going to be coming in right here. Sorry, it's small and hard to see, but there's the tip. Then that flash, that is the PRP bathing the hip joint. And maybe we'll see that one more time. Just kind of paint that flash. Shows that we're in the joint in the right space. Here's some other examples of what it looks like getting a needle into a ligament under fluoroscopy or getting a needle into an intervertebral disc in the low back with X-ray guidance. Okay, well, what is the level of evidence? So PRP has over 73 level 1 studies. Level 1 is the highest level of evidence. And in particular, it's shown safety and efficacy for carpal tunnel syndrome, osteoarthritis, spine condition, tendon and ligament pathologies. How about bone marrow aspirate concentrate, one of our stem cells? 42 level 1 studies, safety and efficacy for osteoarthritis, chondral defects, avascular necrosis of the hip, and spine pain. The fat-derived stem cells, not as much evidence, but is gaining a lot of momentum right now, really good for osteoarthritis. So I'm just going to shorten this by doing our one case that I mentioned originally. So this was our 29-year-old who had really bad low back pain, but had findings of lower leg weakness. So here's all my physical exam findings, but the whole point kind of was we had deficits on the exam, but just because the exam shows these things doesn't mean we have a diagnosis. We need to get imaging to get the diagnosis. Here's what the MRI looked like. So this one here is a normal disc. So we have that nucleus in the middle. We have that annulus on the outside. We have the nerves here in the spinal canal, and they all have plenty of room. And the shape and the color of the disc is normal. This is the level below that. And what we see is all that white that was in the disc, that's called the nucleus. It has pushed out and herniated out here and is leaking out. But not only that, the annulus has herniated and is occluding the nerves and pinching the nerves. And this is what it looks like on the side. So there's these nerves that go out on these foramen, and the disc is directly impinging that. So as a naturopath, and I see that and I see those physical exam findings, I'm like, holy cow, man, maybe this guy needs surgery. Well, no. What did I do? I did an epidural for him. with PRP. And this is what it looked like on ultrasound. If you keep an eye out over here, you'll see the needle tip right there coming in. Now it's in the epidural space, and then I'm injecting epidurally. But I'm not just injecting like cortisone trying to take away his pain. Cortisone's not going to help that disc to heal. Cortisone's not going to really change much other than alleviate pain. I'm injecting PRP, trying to elicit healing. I place the needle with the ultrasound, but then I flip to X-ray to make sure that it's flowing. This is contrast flowing to the level of the disc that it needed to get to confirm it was done safely and in the right spot. Well, what happened with this patient? Because he had those significant findings on exam, I wanted to keep a close eye on him and make sure we were getting this going in the right direction sooner rather than later. So I followed up at 2 weeks, no improvement. I was a little concerned, but he still had pain, but on the exam, the red flag symptoms like the muscle weakness and the decreased reflexes, those had reversed. So there were signs of improvement on exam, just not clinically yet. So I was comfortable in giving it a little bit more time. If those exam findings hadn't have changed, I probably would have sent him to the surgeon pretty pronto, but luckily they had. So I waited another 4 weeks. And at that point, he came in, he was so excited, 95% improvement, no leg weakness, no low back pain, able to work again. And then at 3 months, same thing. Um, he was doing really great. We're still waiting to get a post-op MRI to show how much that disc has healed or not from that single injection. But this here is ODI, and this is the Oswestry Disability Index. This is an outcome measure that we use in PT and other professions to kind of gauge how the low back pain is affecting a person's life. And a score of 0 is what you want. A score of 100 is the worst. So when he came in, he had a score of 62, and at 3 months, his score was 0. So he was doing great. Um, we'll skip this case other than to show that here is a big Achilles tendon tear. So this white area is a gap in the tendon. And here's another view of it. I injected stem cells all the way, filling both of those sides together. And this is an MRI a year later showing that that tendon had completely healed. And I've got several more cases. We've healed some cartilage, but now time for questions.